The hERG potassium channel is essential for cardiac repolarization and maintaining a stable rhythm. When it's blocked, even unintentionally by drugs, dangerous arrhythmias can occur. Understanding hERG function is therefore vital, both for cardiac physiology and for safe drug design. hERG stands for Human Etheragogo Related Gene. You might think that's a strange name, so what are its origins? The name comes from an observation in mutant fruit flies. A defect in a particular gene caused their legs to shake or twitch when exposed to ether anesthesia, almost like dancing. This reminded scientists of go-go dancers from 1960s clubs. Think of them as early dance influencers. The name stuck, although hERG's systematic name is KCNH2. hERG encodes the Kv11.1 alpha subunit protein, which has 6 membrane-spanning segments, S1 to S6, and large intracellular N and C-terminal domains. The S4 segment contains positively charged amino acids that sense changes in membrane potential, making the channel voltage sensitive. At rest, the inside of a cell is negative relative to the outside, which pulls the positively charged S4 residues inward, forming the activation gate and keeping the channel closed. During depolarization, the inside becomes more positive, repelling the S4 charges upward, which opens the channel. 4 Kv11.1 subunits assemble into a tetramer, forming a central pore for potassium ion conduction. The channel also associates with the beta subunit MERP1, encoded by KCNE2, which modulates its behavior. This cartoon represents the fully formed channel. When closed, the S6 helices cross near their intracellular ends, forming the activation gate and preventing potassium ions from entering the pore from the cytoplasmic side. The selectivity filter at the top of the channel, which allows only potassium ions to pass, is inaccessible because the activation gate is closed. When open, the S6 helices of the activation gate move outward, forming a continuous path from the cytoplasm through the selectivity filter, allowing potassium ions to exit the cell. However, the selectivity filter can collapse while the gate remains open, making the channel inactivated. In this state, the pore is structurally open, but ions cannot pass. This inactivation mechanism, through the selectivity filter, is unique among potassium channels and gives hERG a critical role in shaping the cardiac action potential. hERG channels underlie a potassium current in cardiac cells known as IKR, where I stands for ionic current, K for potassium, and R for rapid. So, IKR is the rapid delayed rectifier potassium current. It's best illustrated by looking at a voltage clamp experiment, where the membrane potential is held at specific values that can be changed instantly. This is a typical protocol used to activate potassium channels. The membrane is first clamped at -80 millivolts, near the resting potential of a cardiac myocyte. It is then stepped to +40 millivolts, roughly the peak of a cardiac action potential, and held there for 1 second. Finally, it is stepped back to -50 millivolts, a potential where most potassium channels would close, but where any open channels would still give rise to a measurable outward current. At minus 80 millivolts, there is no current since hERG channels are closed. Depolarization to plus 40 millivolts induces a rapidly activating current as hERG channels open, which persists until the cell is repolarized. When the membrane is stepped back to minus 50 millivolts, there is an initial large increase in current, and that is what makes hERG channels unique. Most potassium currents decrease upon repolarization because the driving force for potassium efflux is reduced. So, what's going on? Depolarization initiates the transition of hERG channels from the closed to the open state. They then enter the inactivated state. For most potassium channels, this transition is gradual, but in hERG channels, the unique selectivity filter-based inactivation is very fast. So fast that channels inactivate more quickly than they open. As a result, the current measured during depolarization reflects only a small fraction of channels that are open. Most are inactivated and non-conductive. When the membrane is repolarized to more negative potentials, hERG channels rapidly recover from inactivation, briefly returning to the open state before closing. The time spent in the open state during repolarization is significant because the recovery from inactivation is faster than channel closure or deactivation. This means that the largest outward potassium currents are recorded during repolarization from a depolarized potential, not during depolarization itself. Here we see a typical ventricular action potential. I'll now superimpose the IKR current to show how it contributes. When the cell depolarizes at the start of the action potential, hERG channels begin to open, but they do so slowly and they inactivate very quickly. Because of this, only a small fraction of channels are actually open and conducting during the plateau phase, when calcium influx keeps the membrane depolarized. As the membrane starts to repolarize, with other potassium currents increasing and calcium current declining, the story changes. hERG channels rapidly recover from inactivation and briefly reopen, while deactivation, their closing, occurs more slowly. The result is a surge of outward potassium current exactly when the cell needs to return to its resting potential. This outward current helps drive repolarization and terminate the action potential. This balance of slow activation, fast inactivation, and slow closure gives hERG its distinctive timing. It's the key current shaping the final phase of repolarization. If hERG function is reduced, for example by a mutation or a drug that blocks IKR, repolarization is delayed and the action potential is prolonged. On the ECG, this appears as a lengthened QT interval, the defining feature of long QT syndrome. Delayed repolarization increases the risk of early after depolarizations and ventricular arrhythmias, such as torsade de pointes. Now let's look at a nodal cell in the sinoatrial or atrioventricular node. Nodal cells generate spontaneous rhythmic action potentials, allowing them to act as pacemakers, although the atrioventricular node's main function is to act as a relay station, controlling conduction from the atria to the ventricles. Nodal cells lack the strong inward rectifier potassium current that stabilizes resting potential in ventricular muscle. So repolarization depends heavily on IKR. During the nodal action potential, hERG channels activate slowly as the membrane depolarizes and inactivate rapidly, much like in muscle cells. But as repolarization begins, hERG channels recover from inactivation and remain open long enough to provide a surge of outward potassium current that completes repolarization and helps set the maximum diastolic potential, the lowest membrane potential reached during diastole. This outward current opposes inward sodium current via HCN or funny channels and calcium entry, ensuring each pacemaker cycle resets properly before the next spontaneous depolarization begins. When hERG function is impaired, repolarization is slowed. Pacemaker depolarization may begin prematurely, and overall pacemaking becomes unstable. These changes can contribute to atrial or junctional arrhythmias or facilitate re-entry circuits in the AV node. Something you might have noticed about the hERG channel structure is the presence of a spacious central cavity just below the selectivity filter. Many small molecules can fit inside the cavity. Also, there are multiple potential binding sites formed by aromatic and polar residues lining the inner surface, which allow the channel to interact with a wide variety of chemical groups. Most blockers reach this site by diffusing into the cytoplasm and entering the pore from the intracellular side when the channel is open. Their presence physically obstructs the flow of potassium ions through the channel. Most blockers also show state-dependent binding. They preferentially bind to open or inactivated states when the cavity is accessible from inside the cell. Some highly lipophilic or amphiphilic drugs can instead partition into the lipid membrane from where they may access the cavity laterally. These drugs can bind in a state-independent manner and may even block closed channels. In this way, hERG is a highly druggable protein. In theory, hERG blockers can be used as class 3 antiarrhythmic drugs to prolong the action potential and repolarization in ventricular myocytes. Examples include dofetilide and sotalol. Unfortunately, the promiscuity of hERG binding means that many unrelated drugs, including certain antibiotics, antipsychotics and antihistamines, can block the channel unintentionally, leading to cardiotoxicity. Because of this, hERG testing is now a mandatory step in drug development. All new small molecules are screened for hERG blockade before entering clinical trials. To sum up, hERG or KCNH2 channels carry the IKR current that's vital for timely repolarization of cardiac action potentials. Their unusual gating, slow to open, fast to inactivate, and slow to close, gives them a distinctive role in shaping the heartbeat. When hERG function is reduced or blocked, repolarization is delayed, the QT interval lengthens, and the risk of dangerous arrhythmias rises. And because hERG's inner cavity binds many small molecules, it's both an attractive drug target and a common cause of unintended cardiotoxicity, making hERG testing a critical step in modern drug development.